that we have so many members of the public with us again. And in particular, welcome to our 3 new non-executive directors, Sarah, Rosie and Umar. Delighted to have you on board. We've had a busy morning already covering off the various different divisions, directorates within the George Eliot Trust, getting an update on their CQC type plans. So really encouraging the level of innovation, the hard work and commitment of our teams, which I think members of the public can be really encouraged about the safety, effectiveness and care of the different departments within the trust. We have apologies from Sarah Collette. I don't think we've got any other apologies. But today is also a special board day in that not only are we welcoming 3 new non-executive directors, we're saying goodbye formally today to Daljit. And Daljit, you have been the most exceptional Chief Nursing Officer for the George Eliot. You have done a phenomenal amount for the population that we serve. You've been a wonderful colleague to the executive board, and you've been a fantastic member of the trust board. You go with our care and affection. We wish you well. We're very disappointed to lose you, but we know how lucky your new organisation is to have you. So thank you very, very much for your service to the people around the George Eliot. So any new declarations of interest? Please raise a digital hand. The minutes of the last meeting, therefore, on the 7th of June, if you weren't happy with those minutes, could you please raise a digital hand? I can't see any digital hands raised, so I will accept those as an accurate record and will duly sign them. We then move on to the action list and matters arising, which is on page 22 of our pack today. And the first was for Jenny to provide the board with a verbal update once the sustainability service has been undertaken and the findings available. This, I think, goes back to some of the discussions on solar opportunities on the site. We're going to come back to that in September, aren't we, Jenny, after the survey's been completed. So thank you for that. And then similarly for the next one, HAC to ensure discussions held at the board workshop regarding productivity are incorporated into the integrated performance report. We've got a new integrated performance dashboard today, so thank you for the work that's gone on behind the scenes there. It's not quite what I was hoping for, in that I was hoping that across the foundation group would end up with effectively identical integrated performance dashboards. So we've still got some differences, but a lot of work's gone on, I know, HAC, on that. So thank you for the work in progress. And then the board secretary ensure time is protected on future board workshops to discuss visits to wards and departmental visits. We discussed that this morning at our board workshop with Simon and Julie in particular giving us a bit of a briefing. So thank you, Ness, for arranging all of that. And then Simon advised that she'd had several remarks on the Women's and Children Risk Management Strategy, which she would discuss further with Daljit and the team, and that was done. So thank you for those discussions. And similarly on the risk management strategy, Daljit to ensure the last paragraph was amended and completed. That was done. Thank you, Daljit. And then Gertie to liaise with, Sarah to liaise with Gertie to ensure briefings provided on the issues and concerns around workforce. Coming back to that in September. Thank you, Gertie, and thank you for joining us today, because I know you've got COVID, so that's appreciated. And then Kirsty to arrange photographs of the newly refurbished League of Friends Cafe to be presented, and that's going to be done once everything's had its last dash of paint, I think would be the phrase. Then back to Daljit to liaise with Gertie and include a section regarding how we best get part-time colleagues back to work. We'll come back to that later, but that's going to be mainly happening from August onwards. And then Catherine and Gertie to ensure the gender pay gap be given further consideration, and that'll be undertaken as a future workshop. That's programmed for October. Thank you for that, Catherine and Gertie. And then Dowjit to explore making the quality accounts even more relevant, similar to the way the annual operational narrative was produced. We'll come back to that at the end of the year with your successor, Dowjit, who has big boots to fill, I think would be the phrase. Then some carried over, but it's been covered off, is that Robin, you're going to give us an update on the metric showing delays in mental health referrals.
Yes, that's fine. Thank you, Mr. Chairman. So we've this data will find its way into the IPR next month, and obviously in line with the new changes. So that's where it will appear from this point going forward. In April, we had 85 patients come through ED with mental health as their primary cause for being in ED, and in May we saw 88 patients. Their average time spent in ED was 7 hours in total. That did come down slightly from April to May, but obviously further improvements and some close working going on between the ED and the mental health teams in order to progress that. But we'll see that in the same style as the rest of the IPR reports going forward. Okay,
thanks, Robin. And great to have you sort of getting your feet under the table now. And then our next point was on the impact on of us on care home closures and the challenges on domiciliary workforce. Coming back to that in September. In October, we'll come back to the electronic ward dashboard which has been implemented and worked on, and once that's live on the wards, Dowjit's success will bring that back in October. And then finally for September, Dowjit's success to provide a more detailed analysis regarding birth rate demographics in response to Keith Condacor's question. So we'll come back to that in September. Are there any matters arising that I've missed, teams? Please raise a digital hand if you think there are. Just for members of the public knowledge, next month we are having a board meeting, but it's a 3-board meeting for the foundation group. We're holding the first one in private because we just want to make sure that works as a process, but they will be public meetings in the future. So there is a board meeting next month, but the first meeting in the public where you'll see us again is in September. So move on to things all strategic. Glenn, do you want to tell us how you're seeing things, please?
Thank you, Chairman. I apologise for a rather long report this time, so I'll not go through every word of it. You'll be pleased to hear. What isn't in my report is happy 74th birthday to the NHS today. So we'll be celebrating in a bigger way next year, I'm sure. So firstly, and most importantly, the opening of the Serenity Garden. That's one of the things we reflected on this morning when we looked at the work of the divisions. It was a really great day to have the Secretary of State come and join us at George Eliot and to have a few words with him about some of the things that we're hoping to do next also. But well done to the team that created that project, and the huge support from the community was demonstrated with both the fundraising and the attention that it's had. So it's great to see that up and running. I then reflect on the messenger review of NHS leadership. Probably a bit underwhelmed by it personally, but there's nothing wrong with the recommendations in the report, but I think it could have more helpfully put in context actually that the NHS spends very little on leadership and management, certainly compared to other industries and to other healthcare systems in the world, and it's something that we maybe need to reflect on. But all those recommendations I'm sure will be followed through nationally and locally. Then a more important report, in my view, the fuller stocktake of primary care, not just because I was involved in it, but because it actually is a really important milestone that it takes forward primary care in the context of the new integrated care systems. And I'm also pleased to let board members know that Claire Fuller's agreed to come and talk to our board meeting in August about it, which is sadly for members of the public is our private board meeting, but it'd be great to hear directly from Claire about how that's going. There's a number of recommendations. I won't go through them all, but I do highlight a number of recommendations that are relevant to us locally. Some things are for national action, but recommendations 1, 3, 4, 5, 6, 9 and 10 are things that we need to reflect on. And we have to an extent already reflected on a number of these because they back up what we described as our signature moves as we move forward into hosting the arrangements for place in Warwickshire North. But you'll see a lot more as we move forward about some of those things, particularly the way we need to work together to address some of the workforce challenges. There's then some changes to provider governance. This is particularly relevant for us here at George Eliot in that it introduces a new code of governance. And these are draft at the moment, but they will be in place soon. Over in South Warwickshire, Foundation Trusts have had to demonstrate compliance with a code of governance for a number of years now, but the same code now is applicable to NHS trusts as it is to foundation trusts. And code-based governance is very much used in other sectors in the UK. And certainly my experience of it in the foundation trust has been that it strengthens things. But what it will mean for us, if all of these recommendations are accepted, is that we will be giving more assurance that we are complying with the code, and we'll have to demonstrate the evidence that we're doing so. And it updates the code that's been used by Foundation Trust with probably 3 important things. One is about our responsibilities to work at system level and as system partners, but also our work with provider collaboratives. But then also it introduces much more of a focus on deprivation and dealing with health inequalities. So we will be preparing ourselves to comply with that once it becomes law. Draft guidance on good governance and collaboration, so that backs this up. So it's telling us the things that we need to be doing as a trust in the new system, and that duty to collaborate is set out in that particular part of my report. There's then an update from the Surgery Directorate, and we saw a lot of great work from surgery this morning as we looked through all of the divisions. But just like to put on record my appreciation for the work they've been doing, particularly on managing the long waiters on our waiting list who have achieved the milestone of having no 104-week waits was something we did relatively early as an organisation. We're now ploughing ahead with an ambition to achieve no 52-week waits at some point during this year, which would be well ahead of the national milestone. My only caveat as I say that is that as we are in a good position, we will be offering our capacity to help other systems around us. And over in Leicester and over in Birmingham, there are particularly long waiting times. So we might see some patients joining our list that are transferring in from other areas to be treated more quickly. But that's huge testimony to George Eliot team that we're in a position to be able to do that. There are some areas of challenge that the directorate is working on. We do need to ensure that we deliver more outpatient activity, particularly, and that shows in the numbers. We will talk later about where we are against the elective recovery milestones. And I think now that we've got really good control of urgent care, that we've got more elective capacity, and the transformation that we describe here in outpatient should get us to a position where we're well above the national target to achieve 110% of historical activity levels, pre-COVID activity levels. There's then an update from the health and wellbeing team. And then finally, we celebrate Dr. Sam George, one of our anaesthetists and intensivists who's received an award for his research as Principal Investigator of the Year for the West Midlands Network, which is brilliant accolade for him, but also for for the trust, which is not as big as some of those university teaching trusts, but does its research and smashes that out the park generally from the size of the organisation. That's all I wanted to highlight.
Thank you, Glenn. As ever, very comprehensive. Questions and perspectives to Glenn on Glenn's report, please. Julie?
Hi, Glenn. I thought it was a really good report, as always. I think it's great that you were so actively involved in the Fuller report, which is a great report. I've had the opportunity to read it as well, and it's great that Claire's coming next time. In terms of the new code of governance and everything that entails, I just wondered if there was something there, Glenn and Russell, for audit committee to actually get involved with in terms of giving assurance around a framework going forwards in terms of compliance.
Yeah, I think that's a good suggestion. I mean, audit committee can look at the processes that we're putting in place to ensure that when it does come up for the board for certification, that we've got some assurance that it's adequate. And say helpfully, it's something we've got some experience of it in South Warwickshire, so Sarah will help us through that. But I think it's an absolutely core role of audit committee to make sure that we're happy that it's based on some substance rather than just an assurance at board level.
I agree absolutely, Glenn, that the fact that we're part of the foundation group should make that whole process much easier for us to get right. I actually think the code of governance has far more consequences on the foundation trusts in the NHS, and in particular the role of governors. There's more in there which arguably further take away some of the independence of foundation trust, which was part of the original, I think, Alan Milburn vision of what foundation trust could be, like academy schools, which I do find it disappointing generally that the NHS isn't sort of giving more liberties and freedoms to the high performing organisations, and I think that is something to be watched. Sarah Rastrick, welcome.
Thanks very much. Thanks, Chair. No, just to pick up from the report, just as a comment, the health and wellbeing team that you mentioned, I think I just wanted to say there, I think some really positive things, the Thrive at Work accreditation, and then that focus on mental health, menopause, financial hardship access for staff, especially as later on in the meeting we'll be looking at workforce and issues of retention and the difficulties there. So I think having this and having champions within the workplace, really, really positive.
Yeah, thank you, Sarah. And any other comments? Otherwise we'll move on. Just to reinforce Julie's point for me, Glenn, thank you for all the hard work you put in at a national level. It does allow us and all elements of the foundation group to outpunch our weight, if you like, because of the various different work streams you're involved in at national level. So we'll move on then to our update on our green plan, the sustainability strategy for Q1. Jenny, what would you like to pull out here?
Yes, thank you very much. So I'd just like to advise the board that this is a slightly different report than you've previously received, because it is a report that's setting up reporting on the Green Plan and is a move from our previous sustainability action plan, which preceded the Green Plan. Just a couple of things to pull out of the report. Just to say that we have pulled together our programme approach to ensuring delivery of the Green Plan and identified our focus leads associated with each of the focus areas that we set out in the Green Plan when we presented it to the board last time. We had a workshop to that effect to bring that team together, which was opened by David Eltringham, and we set out in the report some of the key outcomes from that workshop, which has given us a really good platform to get good engagement across all areas of our organisation to take forward the key focus areas that are outlined in the Green Plan. The other section that I would just like to just draw attention to is the fact that we have, working with our colleagues in South Warwickshire Foundation Trust, as part of the group, pulled together a proposal for funding to support a behaviour change programme, and we're waiting to hear the outcome of that, but hopefully that will give us the opportunity to really sort of look at the behaviour change that sits behind an ability to sustain sustainability activity across the trust. The report also sets out some specific things that are happening in relation to our estate, and refers to some of the key areas of focus in relation to our estate around sustainability. And then finally, the report sets out some key dates for communication opportunities that we're building on to make the link between sustainability and health. And also, finally, I'd just like to remind people, if you're not already aware, that moving into July, it's Plastic Free July. So we will be doing events around plastic free coming up as part of that comms campaign. Happy to take any questions.
That's great. Thank you, Jenny. Any questions or perspectives to Jenny? Glenn?
So, Jenny, it's great to see the work that's going on and your background behind you today. I think one of the challenges for us, and again, this is probably something we need to try and develop across the group, will be that local procurement sustainability issue, because sometimes that will mean that we're not necessarily going for what appears to be the cheapest price solution, that we're going for the local sustainable solution. So we somehow need to factor in the trade-off between price and an investment in our local economy, which won't be an easy one to work through, but I'm sure there's some methodology we could develop across the group.
Yeah, thanks, Glenn. And Sarah?
I'm sorry, I won't be this vocal all the time. Apologies, Chair. I'm just very excited to be here at my first meeting. And just in this, Jenny, I think there may be a slight disservice in the front sheet of the paper that actually I think this does have an impact on equality, positive impact on equality. If we get sustainability right, then this is going to impact people that are actually probably at the margins and really help with equality. So I think there is a health inequalities angle to this as well. And also just reading through the paper, and just wonder as well whether over time having some non-executive sort of backing, looking at the people that are involved. I know we've talked earlier about some of my colleagues having expertise in this area or interest might help as you go forwards.
That's great, Sarah. And I think if anyone wants to volunteer to get close on this, it would be greatly welcomed. But I agree with you. I think that particularly for the younger members of society, which I now count as anyone under the age of 40, one shouldn't underestimate how important having integrity around sustainability and climate change is to where you choose to work. So I do think it has not just an EDI aspect, but it also has a recruitment aspect. Just one further thought from me, Jenny. It sort of goes back to the action point in Councillor Condicort's original challenge, which is probably about 6 months ago now, around solar. I think that there is almost an inevitability that the oil price increase that we've seen in the last 4 months will become the new norm, and gas price increases will become the new norm. So it is extremely enlightened investment for us to invest in solar as quickly as possible. So I think that a piece of work that I know is going on behind the scenes is going to become disproportionately relevant when you do the business case on it. Thank you, Jenny. Colleagues, happy to move on? Okay, great. So we'll move on then to the Safe Nursing and Midwifery Staffing report. Some fantastic progress on midwifery recruitment, but over to you, Daljit, please.
Yeah, thank you very much, Chair, and I'll pick that up in a moment. So the report does highlight a reduction in staff sickness due to COVID in May, but just to advise the board that we're seeing COVID numbers go up nationally and locally, so that's likely to change during June and July, and the board will receive the impact of that at its next meeting. We're also continuing with our nurse recruitment, but it is challenging nationally and locally. We're making some steady progress to recruit into those vacancies. Our biggest vacancy is for Band 5 nurses, and I'm pleased to say that the Trust Management Board has now agreed an international recruitment business case to appoint 72 nurses over a period of 18 months, which is going to have a really significant impact on those vacancies. But I just want to emphasise that international recruitment is a part of a number of other initiatives that we have in place to look at recruitment and workforce development and retention, and certainly in the short term will help. The last time we did international recruitment was in 2019, and it was very successful. We still have many of those nurses still here, so that's really positive. And I'm also pleased to say that as part of the international recruitment process, we did some work to get some of our healthcare support workers that were international nurses trained and registered with the NMC. So that's a bit we've been focusing on. And this programme is looking at international nurses from abroad, and we're working in partnership with SWIFT to do that. So that's going to be an exciting piece of work, and more news I'm sure will come in the future. In terms of our healthcare support workers, we have recruited another just over 15 whole-time equivalent. There is some work underway with the nurse education team to consider what more can be done to recruit and retain into these roles. We have got some early anecdotal evidence which suggests that some of our newly appointed healthcare support workers are finding the role challenging. So as a corporate nursing team, we are working with the education team to just understand how we can give greater clarity about the role in terms of what to expect, but also what can we do in terms of preparation around knowledge, skills and well-being for staff, so we can keep these colleagues working with us. You'll see that the number of areas with vacancies over 20% is increasing, and there's additional work in progress to look at enabling greater engagement and empowerment of the ward teams and directorates to take ownership for this recruitment in their areas, looking at the opportunity to undertake bespoke recruitment events and really get the focused events in place. Has highlighted earlier, for our registered midwives, we are looking at an over-recruitment, and we have had some candidates that withdrawn, which is quite natural to happen when newly qualified will apply for a number of jobs and then choose the one that best suits them. However, given that, we are still going ahead to over-recruit, and our maternity services teams are confident that we're going to be able to appoint to all those vacancies, which, given the national picture, I think is something to be really proud of. So well done to our maternity team. We have a very, very positive position for our healthcare support workers in midwifery as well. So overall, I think we've got a strong workforce in midwifery, and I know Claire's on the call, so thank you to her and her team for that. That has enabled us to maintain some really good statistics with our one-to-one care in labour, which remains at 100%, and also our midwife to birth ratio, positive again, was at 1:26. And finally, the report highlights some of the ongoing challenges with our AHP vacancies, and to flag again, that's around occupational therapy and pharmacy. Pharmacy, we've had quite a deep discussion in Quality Assurance Committee, and we'll be looking at the progress that has been made around that in future meetings at the Quality Assurance Committee. Happy to take any questions.
Thank you, Darjit. And that 1:26 ratio of midwives for births is a very, very impressive number. Questions and perspectives, Glenn?
Yeah, it's great progress on the midwife recruitment. Darjit, just going back on the international nurse recruitment, could you just say a little bit more about the ethical considerations of how careful we are on that?
Yeah. So we are following all the national principles and rules around ethical recruitment. So we're not taking nurses from the areas where they're already depleted in that workforce. So it's all within line with the governance that's required nationally.
Thank you, Daljit. And any other questions? Uma.
Great, thank you. Thanks, Daljit. That's fantastic to hear, because having just done an interim role in the NHS, recruitment is certainly the biggest headache and biggest challenge. So I think it's can't be understated really how positive that is in terms of the work going on. Just in relation to the international recruitment, just a quick question. I'm assuming you have, but is there a support mechanism for when they do come here? So there's an approach where they do settle, there's a sense of belonging, they're part of the community and part of the wider work community, because a lot of research has shown that people do come here and then they tend to be quite isolated, and then you have retention levels. So I'm sure there is, but it'd be just helpful for my knowledge to know what we're doing really.
Absolutely. And if I go back to 2019, and that was the first year I was here that we started our international recruitment, we've retained all of those nurses precisely because of that. So their sort of well-being and their support, and we had a huge welcome event for them, where we shared what it's like to work at George Eliot, and we asked them to share where they've come from, tell us about your families, tell us about what it's like to work in your countries. And that really enabled our staff to understand actually the sacrifices that our colleagues are making when they come. And I think the other important point of what you've said is it's about recognizing the experience that our colleagues have got when they come from other areas. Often actually they've got much more experience than our newly qualified here, or some of the nurses we've got here. So we've tried to really centre on that and develop them when they're here. So that well-being, ensuring they're part of the community, that first year is really important. And there's a huge well-being team, and the nurse education team really focus on that as well, enable them to settle in, find somewhere for them to live, just the first week's shopping, how to go to the bank and get money out. All these things are really important, and that's a part of that wellbeing package. And George Eliot's done some really great stuff around that, so I'm confident that that will happen again.
We've spent quite a lot of time as a board in the past assuring ourselves on that very issue, but thank you. Okay, team, we'll move on then on to the report on acuity and dependency and outcomes and the associated establishments. So again, Daljit, what would you care to pull out here?
Yeah, thank you very much, Chair. So the report is summarising the outcomes of the acuity review, which all organisations are required to do twice a year. So the data you have in front of you is our winter one, which is January 2022. And this has been triangulated along with professional judgment and our quality and safety metrics. So it's really important to understand that we don't just make decisions based on what the Safer Nursing Care tool is saying. I'd also like the board to take into consideration that over the last 2 years, when we have done these reviews, and I have highlighted this before, we have done this under some very unusual circumstances, which has been around the pandemic. So you must take that into consideration. That's meant that we've actually had some areas closed due to COVID, and that we've also had to open additional capacity. So the Safer Nursing Care tool is essentially in itself telling us that out of our 12 wards, 10 of those have got higher nursing establishments than recommended, and 2 of them are lower. And again, as I said, I would just sort of take into consideration the context in which the review was done. So that's why it's important to triangulate that with professional judgments and our quality and safety metrics. And that triangulated together, the recommendation is that, we do not make any changes to our staffing establishments on our 12 wards. I'd like to just highlight to the board, especially as this is my last board meeting, that we've not been required to do this for some time now, there for a number of years, which I think is really positive. So, despite our vacancies going up, we are holding on to our establishments, and that's really positive. So maternity undertake daily acuity assessments as well. They use the Birth Rate Plus. We did a full Birth Rate Plus back in 2020. The recommendation is that we do one every 2 to 3 years. So I'm recommending, and certainly have handed that over to the new CNO, that we do one next year. We were looking at doing a tabletop review of our data, which is something that I've asked the maternity team to do, so we can include it in the ongoing report. So we do that twice a year. Now that was reliant on Badgernet, which we talked about this morning in the board workshop that's being implemented. We're having some challenges regarding getting the data out of that, but the team is still trying to see whether we can get something out. But actually, I think our assurance is that our birth rate, our midwife to birth rate remains positive, and we're delivering 100% in continuity of care. In terms of the other specialist areas, you know, there aren't many national tools to look at children, to look at staffing in those, but we know that due to a national issue around challenges with paediatric nurses, we have got some impacts as a result of that on our children's assessment unit. And our new matron is looking at refreshing the plan for recruitment for that. For special care baby unit and intensive care, there are no problems. And you'll have seen from the staffing report that we are trying very hard to recruit in theatres as well, which would be part of our international nursing work as well. In ED, we trialled a very newly launched ED tool, which CNST have developed. It's quite new. There's lots of training happening nationally regarding this tool. We have got our first set of data, which we're looking at, but the recommendation is not to make any changes regarding staffing on that. I think we need to do that a few times to get our expertise around it, but also just to triangulate the data and do some quality assurance. And finally, the report highlights some of the recommendations going forward that in previous meetings, in previous reviews, we've talked about increasing the ward manager supervisory time. So we'll be looking at having those discussions within the organisation at Trust Management Board, and also the report highlights some of the pathway changes in the medical directorate, where there'll be some business cases to look at staffing for Elizabeth Ward, which is our respiratory specialist ward, and the stroke services. Happy to take any questions.
Very comprehensive briefing. Thank you, Dowdy. And we did touch on a lot of this this morning. Any questions from colleagues? A couple of points in the chat box. Okay, well done, Dowdy. It's great you're leaving us in such good condition, so to speak. So thank you for that. And Claire, it's lovely to see you again for the update on progress with Ockenden 1 and Ockenden 2. I assume Nina is still working, not that you're not working, Claire. So Claire, what would you like to pull out of the update?
Thank you. Yeah, just a brief update then, really. Just in relation to Ockenden Part 1, we now no longer have any red elements within Ockenden 1. The elements that we are still having some challenges with relate to saving babies' lives, but there has been some deep dives done in all units around those areas of non-compliance. So we are waiting for our feedback from that still, but that is something that all organisations are having. So we're expecting some support with some of the elements that we're not able to achieve within the organisation. In relation to the personalised care and support plans, as you know, they've been a challenge for a little while. We have now done the self-assessment work, and we're going to spend July now working through that as to how we can try and improve our compliance. But as I think I've said before, we have observed that other trusts have struggled with full compliance with personalised care and support plans. In relation to Ockenden 2, obviously, which was released in March, we've now completed the interim review of that within our own directorate, and you'll have seen that shared in the appendix within this report. 7 elements do require executive LMNS or national steer for all organisations to achieve them. 40 of the elements for George Eliot are green, 52 are amber, and 8 are non-compliant and red. But again, you know, that's ongoing work that is going to take some time to get through and to achieve for all organisations as well. I think it's important to know that we have had a CQC visit in June. That was a visit to maternity only, where we presented to the CQC, and they held focus groups with staff as well. Very successful, and they left very impressed with the knowledge and enthusiasm of the team, and were reassured. And now they have decreased their risk level associated with the service, not just monitoring us as normal with other organisations. In relation to continuity of carer, as obviously that's really really relevant and really important nationally. We are still reporting that following Ockenden that we are have continued to work on the second of the 3 options that was available through Ockenden and through NHS England, and that is to continue with what we're doing, but to cease any further rollout until we have full recruitment and our newly qualified midwives have been within the organisation for a year to continue. That's a lot of information, but I'm happy to take any questions.
No, that's great, Claire. And the combination of you, Nina, and Natasha as leadership team have done a quite extraordinary job. So thank you. And
Thank you.
Again, just to emphasise that we are very critical in our self-analysis to make sure we are absolutely doing the right thing for our mothers and babies. Questions and perspectives, Simone? If you're talking, Simone, you're on mute.
Sorry, Chair. I just wanted to commend the team on the CQC result. I think it's an outstanding achievement in the present climate, and I would like the board to acknowledge that. Thank you.
Absolutely, Simone. Point well made. Thank you. Daljit?
Yeah, thank you, Chair. I just wanted to add to regarding Ockenden and your comment, Chair, about us being quite robust in our approach. And I think that's demonstrated in the CQC saying that they saw what evidence in practice, what the evidence was set them, and it was all triangulated, so they were reassured. So we are very tough on ourselves on that, and for the right reasons. And you know, Claire and the team continue to do some really good work around Ockenden. In addition to doing these staff workshops, you know, Claire and the team are also looking at, as we speak, engaging with service users around Ockenden and what improvements they would like to see. And also I've started some conversations with Jenny about having those improvement conversations across place. So this becomes a really coordinated and jointly owned improvement plan for our community.
No, that's great, Daljit. And I think in your new role, it would be great to keep sort of lines of communication open. So anything you can share with us in terms of better practice, I'm sure Claire and Nina would grab with open arms. And finally, Glenn, then we'll move on.
Yeah, it's just a bit of caution, I suppose, around Ockenden. And it's both reports are great and lots of recommendations, all of which improve services, but it's become quite a maze of actions if we're not careful. And I think it's really important that we have a kind of helicopter view of what's going on in the service, that we still work with the cultural teams, we still look at incident reporting, because there's a danger you just think you're doing it all if you tick all these boxes, and it's much more complex than that, isn't it, Claire?
I completely agree. And I think as well, you know, we're likely to see reports coming from other maternity organisations that are currently under investigation. So I completely agree with you that we need to make sure we're doing the normal day-to-day and the high-level work as well as this in addition.
And if I can just build on that point, Glenn, just by giving a couple of examples, that we need to make sure we don't lose off the narrative, and it's really about population health. I think if we look at the level of obesity of mothers in our units, the numbers have crept up over the years, and therefore it does become a priority for us to help in terms of weight management for expectant mothers, because that has significant impact on baby health. And I think I'm also correct in saying that over the last 10 years, the amount of expectant mothers who are on antidepressants when they give birth is at a record high. In the order of a third of expectant mothers are on a version of antidepressants, which again has significant impact on baby health potentially. So we really do need just to see Ockenden as an absolutely critical part, but the population health management challenges to ensure mother and baby are really healthy during pregnancy and post-pregnancy are where we need to get the debate going. Team, happy to move on? So we move on then to a new version of the Integrated Performance Report. Good to see you back, David. I know it's been a tough few weeks for you. Catherine has held the fort valiantly in this section of the board whilst you've been away, but it's it's good to have you back. So David, over to you.
Thanks, Russell, and I'm glad to be back and to be introducing our new format integrated performance report, which, as you said, has still got some work to do on it, but we thought we'd follow the lead that you set for us, better done than perfect, and get going with it today. We know that it'll develop over the next few months, and we will be very grateful for any feedback and any comments that members of the board might have, and if you could direct those to Hack, he will consider those and take them and work with them to develop further. So the report is set out with a sort of headline overview from me, which is what I'm going to kind of take you through, and then there's discrete reports from each of the portfolio holders who sit within the executive team, and if there's any questions, they'll be only too happy to pick those questions up. So overall, our performance remains relatively strong compared to others, but we had our finance and performance executive meetings with the directorates last week, and we were really clear that we don't just want to be in the pack here or even just lead in the pack. We want to be constantly pursuing excellence and better for our patients and for the communities that we serve. So whilst our relative performance is good, there's still a lot for us to focus on. We've got lots of clearly identified opportunities from service improvement perspective, which will in turn, once implemented, improve our performance further. So I think that's the context of the conversation as we go through it this afternoon. Overall, the hospital remains very busy with high levels of emergency demand and high bed occupancy, and I'll say a little bit more about that in a moment, and that drives a performance challenge, particularly against the ED 4-hour performance target. We have struggled with that through the beginning of May. Things improved as May went on, so the performance coming out of May and into June was in better shape. Last week we were back into the mid 80s, but that's still a distance away from the 95% national standard. So if you think about what I've just said in terms of opportunities for continued improvement, there's still lots of work for us to do there. We are seeing increasing numbers of COVID patients in the hospital. So we got down to very, very low numbers 6 weeks ago. Those numbers have crept back up, and in actual fact, the number of patients is increasing quite dramatically. So we've doubled the number of patients, more than doubled, in fact, the number of patients with COVID in the hospital since Friday. So today there are 44 patients. When you consider we were dealing with 1 or 2 patients just a few weeks ago, that's a huge increase. And of course, that has a massive impact on the way that we run the hospital in terms of infection prevention and control and separating work streams. So some quite challenging situations sitting around our overall performance. Length of stay and discharge obviously impacts on flow through the hospital, and our length of stay and the number of patients who are in hospital who probably don't need to be here are very much higher than we would like. Discharge is an area of focus for us, and we are focusing both on our internal processes and the efficiencies that we can drive through making sure that we make good early decisions following senior review, that every patient has an expected date of discharge, and that we follow through on actions that are set out in discharge plans. So very focused on that, and working with ESIST, the Emergency Care Improvement Support Team, around that. We've got some national directives around 10 areas of focus related to discharge, and we are very much committed to delivering against those, and we're going to report through TMB each month how we're doing against each of the national challenges against discharge. So very much a focus on that, and we're also focusing on those patients who are stuck in hospital but could be cared for elsewhere by working with partners to reduce the number of delayed discharges. And again, that forms part of that same piece of work. And the other thing I want to draw attention to relating to urgent and emergency care is our commitment to keep inpatients out of the same-day emergency care unit. So that's a really important way of seeing people quickly, doing rapid diagnostics and rapid intervention without having to admit the patient, and then hopefully being able to discharge them home. We've got a really nice, high-quality space for that work in the hospital, which we invested in some years ago before COVID. And we've had to use it through COVID to accommodate inpatients. We need to stop that now, and we need to move away from that. And we've made that commitment, and hopefully that again will contribute to improvements in terms of emergency flow. So moving on to planned work, you've already heard the very positive feedback that we've got no patients waiting more than 104 weeks, which is great, and we cleared those patients down well ahead of the elective recovery plan target. We've got no patients waiting more than 78 weeks, which was the sort of second stage of the plan, so that is excellent. And the number of patients waiting more than 52 weeks is reducing at pace, and we expect to have cleared that down by the end of the calendar year. As it stands today, there are 110 patients who are at more than 52 weeks, and only 37 of those left to date. So the majority have got a date, and we will follow through on those other 37 in short order. Now, of course, that does put us in a good position to be able to offer mutual aid to other organisations across the Midlands who are struggling, and we'll do that, and we'll do it in a balanced way in order to support the wider West Midlands and indeed Midlands community, because some of that mutual aid may go towards Leicestershire. That's a really strong position to be in, but of course it does mean that that may impact on our own waiting list position as that mutual aid begins to arrive. Glenn mentioned the need for us to get to the more than 110% pre-COVID levels of activity. So just to again put that into context, at the point where the report was produced, and we're hoping this will have improved through some of the work that we've done over the last couple of weeks, we were managing to deliver 94% of ordinary elective activity, that's inpatient activity, 98% of day cases, outpatients less than 90%. So there's room for improvement against each of those areas of work. One of the things that's missing from the integrated performance report is a statement of cancelled operations, and we'll make sure that that's included next month, because that's really important. And as I've said, we've taken a number of steps over recent weeks to try and improve the levels of activity, which hopefully we'll see in measures. And in fact, Robin and I have been chatting earlier today. We're going to try and create some sort of dashboard so we can see in real time what those numbers look like, rather than waiting for a weekly or a monthly report to tell us. So an important focus for us there to move that up. In terms of other things, workforce availability is a key area for us to stay focused on as a leadership team. If we haven't got people on the ground who are able to deliver the services, then we'll go nowhere. And you can see in the report that there's some quite challenging numbers still being dealt with. We've still got a reasonably high vacancy rate in certain areas, and sickness and absence continues to be a challenge as people continue to isolate as a result of COVID. And you can sort of feel the COVID context again starting to bite on a range of fronts, so that is a risk for us going forward over the next few weeks and months. Notable improvements in recruitment in specific areas, particularly around some medical posts, and we've already talked a bit about international nurse recruitment, which will deliver down the road, so I won't spend any more time on that. And then finally, just to highlight the fact that from a mortality perspective, we have seen an increase over recent months in our hospital mortality measures. They remain within the expected range, but we are very conscious of the shift, and we've commissioned an external review, and the output from that will be available later in this month, and we'll be able to talk about it to board as soon as it becomes available. So those are the headlines. I'll stop there, and happy to take any questions, or for colleagues to answer any questions that relate to their specific portfolios.
That's great. Thank you, David. Questions and perspectives from colleagues? Julie?
David, it's good to see you back. Just a couple of questions, but in terms of the dashboard itself, I think that's really developing and it looks really good. We talked a little bit earlier around the development of a place dashboard. It would be useful to know what sort of things what sort of indicators might be on that place dashboard. My two questions are around, because you've given the latest COVID figures, which is an incredible increase in the numbers of COVID and the implications this means. And I just wondered how we are communicating or working with others to communicate the impact of that to the centre, and because of the pressure that will bring on achieving targets, but also the pressure on our workforce, how that's being communicated, and how we might see a response. But my second question as well is about the performance around 2-week wait referrals and what that actually means for those 100 patients. I'm not quite getting the sense. Does it mean they're waiting 15 days, 24 days? I'm not quite sure what that means.
Okay, let's give Robin a heads up. We'll bring him in on the 2-week wait question in a second. Then let me go back to the beginning. So the place dashboards, actually, just this week I've seen a very good piece of work that's been undertaken. The sort of culmination of probably 18 months work actually from our analysts and the information team out in place. And we need to bring it and show it to board. It's going to our place executive meeting on Thursday, so it's a kind of I suppose if you're an IT person, it's kind of out there for alpha testing, and we'll get it into shape. So it's really good. It's based on the King's funds for domains, and there's all sorts of stuff in there. So in the integration piece, you can see all of the things that we've talked about here today that are very much about health and social care. But then there's a bunch of stuff about education in the communities and wider determinants piece. There's things about air quality and that kind of thing. It's a really good piece of work, and we need to bring it and show it to board, Julie, to bring it for life. So just to assure you that work is in progress. In terms of COVID-19, so the COVID-19 numbers have shot up. They've risen significantly since Friday, more than doubled. And obviously we'll keep an eye on that. You're aware that we used to talk about the doubling ratio, and we stopped because it became irrelevant, and it feels like it's back again, and that's therefore where we're focusing our energy. None of the patients who are in the hospital today were admitted with COVID symptoms, and those admissions are not turning into high dependency or ITU admissions. So there's still a level of containment in terms of the disease. So the pressure that brings into the hospital is around the sort of logistics and the operational management, how we make sure that we continue as much as we can to admit specialty patients to specialty beds, that we cohort where we can, and that we try and separate surgery and medicine so that we can continue to operate in a planned way. And that's where the logistical challenge comes in. And then if you layer on top of that the fact that we've still got members of staff testing positive who are then subsequently out of the mix, that's a further complicating factor. And all of those things are reported up the chain of command through NHS England and NHS improvements incident management route on a daily basis. Robin signs off a report which is then submitted. So they're very much aware of what's happening. What we're seeing is probably no different to what's happening in many hospitals across the country, although there are differences in different geographies. And indeed, Glenn and I were just having a conversation before we came in here about the fact that we're not quite seeing the same picture in the south of the county as we are in the north. So we are talking to people on a daily basis about this, and kind of being very clear with regulators and colleagues in NHSI about what's going on. And we are also talking to our teams, and indeed we've got a Facebook live broadcast tomorrow. I've just written the script, and it's front and centre there. Certainly not off the radar. We need to make sure that we keep our staff involved and briefed in the things that we're doing to manage this as we go forward.
Thanks, David. Thanks, Julie. We are running late now, so we need to keep the pace going. Robin, did you want to ask the question on 2 weeks?
Yeah, just really quickly then, Mr. Chairman. We've got 120 patients are over 2 weeks, predominantly in a couple of our specialties, colorectal surgery and urology. We obviously are working closely with those teams to ensure we've got maximum amount of capacity, and also liaising with the patients directly so we can get them the dates as quickly as possible to be seen. And that is on the backdrop of a national increase in referrals into those specialties. So it's based on not a reduction in capacity, but an increase in activity that's been replicated nationally. And I'm more than happy to pick up offline with Julie any more specific information she might want on that.
Thanks, Robin. Sarah, your hand went down. Are you okay?
Thanks very much, Chair. In the thing of time, something I'll probably pick up in subcommittees as I go forwards, but I'll just put something in the chat. Okay, great. Thank you. Can I just ask on the integrated performance report, it's something I've asked for in the past, but I can't see it, is I want us to see the 18-week RTT as a number, because I do worry that we're drifting into a place as a national health system
where we're normalising performance which historically would be regarded as totally unacceptable. And even if the 18-week RPT is never given to us again as a national target, I want us to know what it is, because I want us to be above 90% on that. And Robin, if you know what that number is, can you pop it into the chat box so that I can see? I'm running a little bit late now, guys, but really good to see the progress. And David, as you said, in so much in life is about better done than perfect. So but let's make sure the integrated performance dashboard is perfect by the time we get to September. So moving on then to the finance report. Hack, tell us about the challenges on the money.
Thank you, Chair. It's quite a complicated picture after 2 months, and that's largely because we've got more moving parts than we'd normally have at this time of the year, and that's partly driven by the fact that we needed to resubmit the plans again in June. But the good news is that we have been able to now submit a break-even plan as a result of getting that additional funding for inflation and for cost pressures. The Coventry and Warwickshire system has also been able to submit a break-even plan. And that's really good news, because the additional capital funding is dependent on systems having break-even plans. So if we hadn't been able to do that, our potential funding for phase 2 of the CDC might have been compromised. So it's really good to see both ourselves and the system having break-even plans in place. Having said that, the changes to the plan are not yet reflected in the paper that you've got today, because that happened too late for that to be done. So from next month we'll reflect the new plan, but combined with a number of one-off elements, the position to date is a bit difficult to interpret. So I'm just going to cut through all of that and kind of tell you what the position would be with a new plan in place, because that's what we need to be monitoring against. So after 2 months, based on that having that additional income, we would have a deficit of £500,000 after 2 months. Now, that's not significantly off track based on the phasing of our plan. So the phasing of our plan shows a deficit in the first quarter that we then recover in subsequent quarters. So David's already covered the operational challenges that we're facing, and those challenges are largely driving that deficit that we've got at the moment. So as David said, in May we saw a high emergency demand, a lot of our beds taken up, including in all the surge areas, and that consequently has an impact on staffing costs, but also on elective activity. So as David said, we got just over 90% of pre-COVID levels of activity by value in May. That was a significant improvement on the April figure. David mentioned having a daily dashboard. We've actually got one in draft version at the moment, and we'll be live with that hopefully by the end of the week. So every day we'll be able to see our recovery position. Looking at that draft dashboard, what I can say is that the June position for elective inpatients is over 100%. We're at 105. We're over 105% on elective inpatients. But as David said, we need to do a bit more work on outpatient activity, so we can see that the numbers, particularly on elective inpatients and day cases, are improving and getting very close to where we would like to be. In terms of risk to the position, one of the key risks is that we have assumed all of the elective recovery fund income for the first 2 months in our position, even though we haven't earned it. That's been done in agreement with system partners, so everybody has done that collectively. There is some risk nationally that they might claw it back. I believe it's unlikely, but nonetheless it's a risk, so I'm flagging it here. Also, the ERF payment mechanism is quite complicated, and they are reviewing that nationally, so it's still not clear exactly how that will work going forward. But having said that, that doesn't make any difference to our focus, which is on treating as many patients as quickly as we can and as efficiently as we possibly can. And that links back to what David said in terms of our focus areas around reducing bed occupancy, reducing the length of time patients are waiting for their treatment, and increasing staff availability. And those all directly relate to the risks to our financial position and things we need to focus on to improve our financial position. So on a positive note, in terms of our expenditure, we have seen our expenditure reduce over the first 2 months of the financial year. So I do take some comfort from that, some assurance around ownership of budgets and controls across the directorates. And just to finish off very quickly on capital, the expenditure today is largely related to projects that were carried over from the previous year. that includes phase 1 of the CDC, which is due to be completed and handed over to us by the end of the month. I'll stop there and take any questions.
That's great. Thank you, Hack. Questions and perspectives to Hack? Hack, just one thing from me. If we could, as part of, obviously the ICB has now become a legal entity on the 1st of July. I think it would be good if we had something regularly in your reports, which was just the system's finances, just so that everyone is aware and we subconsciously recognise our part within the system. Because I think I'm correct in saying that in terms of the acutes, we've got a break-even plan. I believe Swift has got a plan which is positive, but the system is still losing money because of a significant deficit of UHCW. But it would be good to understand and contextualise our numbers in the system numbers, if you could, Hack, going forwards. Thank you. Any other questions to Hack, Simon?
So just on that last point, are any non-execs from the system sitting on any of the ICB committees?
No.
Thank you.
And that's different from other ICBs. So, for example, in Hereford and Worcester, I chair the finance forum for Hereford and Worcester still, even though I don't sit on the ICB board. Sarah Rastrick, our new non-executive, does sit on that Hereford and Worcester ICB board, but the decision was made in Coventry and Warwickshire, and it's been the case for quite a while in Coventry and Warwickshire that the subcommittees have not been chaired by non-execs, whereas in Hereford and Worcester, by example, they've always been chaired by non-execs. And I have to say I've been uncomfortable with that position for a long while, because the purpose of a non-exec is to be independent. But answering your question, Simon, the answer is no.
Thank you. I think it's even more important then that we see the system position across all the indicators regularly.
Absolutely. And any other questions? Okay, we'll move on then to the summary of ratified policies. David.
Yeah, thanks, Russell. I'll take the paper as read. There's one policy that was approved by the policy review group. That was the clinical audit policy, and simply reporting that to board. Okay,
any questions on that policy? Okay, thank you, David. Members of the public may not be aware, there is an ocean of work that goes on behind the scenes by members of the management team on issues like ratified policies and development of policies and protocols. So thank you for everyone on the work face, so to speak, who does that stuff. Then the board assurance framework, finishing off the end of year position and the Q1 high and extreme risks. David and Darjit.
Yeah, Darjit's going to talk to this.
Yeah, thank you very much, David. So the first thing just to highlight to board is that the management and oversight of the BAF has now been handed over to the Quality Governance Department, which is my reason for giving a summary on this. So this paper basically gives a review of the risks for the BAF in 21-22 and the completion of the new BAF for 22-23, which has been undertaken by the executive lead, so they've got full oversight for their areas. Then we have some further scrutiny as per our governance processes, which has been undertaken by the Executive Risk Committee, and then with Anil as the non-executive director lead for finance, and for the quality and safety risks, this went to the Quality Assurance Committee. So the report's essentially highlighting the risks that will be removed or transferred over to the new BAF. But alongside this, I just want to inform board that we've taken the opportunity to review the risk register coming out of some of the COVID work that we've had, which has meant that the directorates have been able to attend some of the meetings. We cancelled some meetings. We're doing a real refresh of our board to board risks, and we're also alongside this looking at the system risk register and the BAF. So the governance team are just ensuring that the BAF, the system risk register, and the risk register within the organisation are all aligned, and you know, the wording of them demonstrates the level of risk that there is. So I'm requesting the board to approve the BAF for 21-22 and our end of year position, and recommend that we go forward with 22-23.
Thank you, Daljit. Any questions or perspectives regarding that recommendation, Julie?
Hi, thanks, Russell. Not regarding the recommendation, which I support. My question follows on, I guess, from Simon and Russell's last comment, was around, is there a system oversight group for risk so that there will be a mechanism for escalating up to, and you're nodding, so I'll leave that if you're going to answer.
No, so well, it's all work in progress at the moment, Julie, but it is being discussed. So we do have a system risk register, and that currently goes to the quality surveillance group, of which the CMOs and the CNOs are members. So that's the risk register we're working on at the moment, but they are working this through in the system, and there'll be some very clear processes around how risks are raised within the system and monitored.
Very great, thank you, Daljit. Thank you, Julie. And Sarah?
Yeah, kind of similar point really there. I wanted to say about the triangulation with the board assurance framework and the risk framework within the system and at the ICS. I think it's going to be really important for us as a board to make sure that we're cited, especially where we may be named as a risk, that it's really important we've got assurance as a board there. But I was also just going to make an aside comment, joining this late, and obviously we're agreeing something that is passed. I think despite my comment about some of the articulation before, I think the way that things are articulated in this board assurance framework really resonate with the values of George Eliot, and I think that that's really positive, and the work that's gone in there to have significant risks in the board assurance framework reflect the ethos and values, just in the way that some of the things that are put is really, really positive. So to all the hard work that's gone in there and how that pulls as a thread all the way through, really, really good.
Thank you, Sarah, and thank you for that observation, which is helpful from someone who's just recently joined us. And finally, Glenn?
Yeah, as you all know, I'm very supportive of the ICS changes and the really great opportunity for us to achieve better integration focused on prevention. But I actually think the strongest integrated care systems will be built on the strongest governance within the organisations that make them up. So I think really important thing for us is to maintain that absolute focus on the things that we're doing, and for the ICS to look at the joining up and potentially any cracks in the system that need to be addressed. But they need to rely on our governance, and that's something I know Russell's liaising with the integrated care system non-execs to kind of build on our own governance.
I think that is an absolutely key point, Glenn. What we can't allow is the ICS just to put in another layer of duplicative assurance and process. It's got to be additive, and as you say, focus on the areas where things are dropping in between the cracks. And so I think we all need to be diligent on that. Equally, what we can't allow to happen, and I know we wouldn't, is a sense of, oh, well, it's being covered by the ICS, we don't need to worry about it. If it affects our citizens, we need to worry about it. So I definitely don't want to lose that focus either. Okay, team, so happy to accept, if you're not happy to accept Daljit's recommendation, please raise a digital hand. Okay, thank you, Daljit. I'm sure you're actually changing role just purely because when in the new role, you'll be able to take more of a breather, given that about 70% of all of the talking done in the public board is done by you.
I think you're spot on, Chair. I've been to their meeting, and there aren't that many reports with the chief nurse.
We need to learn the lesson. Okay, Tim, so we'll move on then to the medical appraisal and revalidation annual report. Catherine, what would you care to pull out of this annual report?
Thanks, Russell. Well, this is the annual report from the responsible officer, as this is one of the requirements for the board to sign off the statement of compliance, which is attached as an appendix. Basically, there's a lot of assurance around the state of medical appraisal and revalidation. It's been subject to an internal audit this year, and we've also, Glenn will like this, done a peer review with Wye Valley, sharing best practice across the group. That was a really useful exercise for both of us, and the risk that we identified from that has sadly come true, that in terms of succession planning, the medical appraisal and revalidation manager in both organisations is a sort of single point of failure, and unfortunately ours has just announced that she is leaving the trust in July. I really want to say a big thank you to Chris, because she has done an enormous amount of work to get us into the good position that's reported in this paper here. I would also like to thank Rajiv Nair, who's one of our consultants, who was the appraisal lead. He has retired from the organisation and gone off to Canada for a new life. But he did a lot of great work, and his role has been replaced by Vinod Patel. So I'm happy to take any questions on the paper, but the position in terms of medical appraisal and revalidation is a really positive and strong one for the organisation.
Thank you, Catherine. Any questions or perspectives to Catherine? No, great to get that sort of cross-fertilisation of ideas and approaches across the foundation group. So thank you, Catherine. Now we therefore move on to the medical education annual report. I mean, it is one of the things we can be really proud of at the George Eliot, is our work on medical education. So Sankara, Delia and Louise, lovely to see you this afternoon. What would you care to pull out of this report?
Thank you, Chair, and I think thank you for this opportunity. I would just like to say, as you'd mentioned, education has been one of the kind of the shining stars of George Eliot for a long time, and that's continued over the last few years and over the last 12 months as well, which has been, as you can imagine, particularly challenging with regard to the opportunities as well as the kind of the gaps in where we could actually provide some of this education, both for trainees as well as for medical students as well. But I'm really, really proud of the team and the way they've actually got together to actually deliver on this and found innovative ways of delivering this education. And that's what we hope to take forward over the next 12 months as well. We really want to invest more in technology enhanced education and look at new opportunities as well to try and deliver on this. And I think we are going from strength to strength in that. I mean, I have obviously, as you mentioned, two of my close colleagues with Delia and Louise, but I have to say that we need to send a special shout out to the rest of the team as well. People like Kay Harrison, Sam Cook, and a lot of the others, Justine and Lisa, all of them have actually tremendously supported this endeavor over the last few months in a very, very difficult situation. As you all know, we are still not out of the pandemic, whatever the government might say. We still seem to be heading in the wrong direction in some ways, but the trust has got together to do a lot of work on this, and I want to make sure that we carry on with that work in education as well.
Well, Sankara, very well said, and I think a big round of applause from all of the board for everything that's continued to happen with our education work. Catherine, is there anything you'd like to add?
Yeah, I think the teams have done an amazing job, as always, and as Sankara says, it is a jewel in our crown. I think there's just a couple of points that I just want to emphasise. So we've seen an increased number of placements, educational placements being offered at George Eliot in postgraduate training. And I think we should take heart from that, because that's a sign of confidence from partners in HEE in terms of the quality of the education that's being delivered. That comes with a bit of a double-edged sword, because unfortunately the deanery has not always been able to fill those posts, and we're doing quite well on medical recruitment into trust grade positions and those doctors going on to get training places, but we are suffering a bit when we are not getting the training places that we've put out filled, and that does put a pressure on teams that then don't have staff available that we need to fill through our own local recruitment. But in general, it's been a very difficult time for educators and those in training, and it's great to see such a positive report and the innovation that continues despite the challenges.
Well said, Catherine. And Sankara, did you want to come back in on that?
Yes, I just want to kind of add to what Catherine is saying. I think we are aware of the issues with recruitment and the gaps which HE sometimes leave us with. We have been proactive at recruiting to that with the service leads. And part of that is also actually putting in now a coordinator for international medical graduates, because we do recognize the kind of particular challenge that this cohort of trainees face. I think a couple of years ago, we actually had one of them actually present to the board, if I remember. And this is something which we've kind of taken on very seriously. We've actually now got a clinician who's actually a lead coordinator for international graduates, but we've also got an admin coordinator for the kind of needs that they may have when they actually start in the trust as well. So similar to what some of our nursing colleagues have achieved with overseas recruitment with nursing, we actually hope to actually expand on this as well, because I think that's a really good resource. And we've got them presenting on national conferences as well in the next few months.
Okay, great. And finally, Simone, because we are running out of time.
Thank you. Just to say, it was incredible to read this report, given the context in which the work was done. So quite incredible to see that. It made me think that it would be great if we could see something similar for the rest of the workforce. Who has access to paid development? Could we have that broken down by ethnicity, for example? Could we have it broken down by department, so that we can understand the training and development activity across the rest of the workforce? I guess Gertie's going to tell me that that's difficult with our information systems, but it's a bit of a blank at the moment.
Okay, Gertie, do you just want to quickly come in on that?
Yeah, I guess Simone is right. It is difficult, but I think there's certainly a level of detail we could bring in. And what I'll suggest is I'll take this offline with Delia and colleagues, and we'll maybe take a slightly more detailed report at a point later after the summer into the QAC committee.
Okay, great. Thank you, Gertie. Thank you, team, for all your hard work.
Mr. Chair, can I just interrupt just to kind of add one more thing to that? Since the report's been written, one of the successes we've had, which we ought to highlight to the board, is the fact that we've also been selected as an endoscopy training academy at the George Eliot, and that's a huge feather on our cap. There's like 4 trusts in the West Midlands who've been selected, and we are one of them. So with my other hat on as clinical lead for gastroenterology, I'm obviously very proud, but it's also an opportunity for us to showcase our talent and our kind of success in this way. And I'd want the support of the entire exec team to kind of make this a success. We're going to have trainers coming from all over the country into our trust in about less than 4 weeks' time, looking at our endoscopy unit and actually delivering some of the training nationally to some of the trainees. And I think it's really, really important that we have operational and executive support for this to make sure this is a success, medium and long term. Thank you.
Okay, no, thank you. And thank you all for your hard work. And Louise and Delia, thank you for everything that's going on behind the scenes. Please pass the board thanks down to the front line. Okay, team, we're running a bit late now. We've got the AGM ticking away as a drop dead time. So we'll move on then. And if I can ask on the subcommittee chairs updates for us to do these pretty rapidly. So the first is the QAC of the 30th of May and the 27th of June. Simone, what would you like to brief us on?
Chair, in the interest of time, everything that I might have said about the June meeting we have covered. Workforce, mortality, Ockenden, all of that. So just to say, it's great that the committee is aligned with what the board wants to talk about. That's all I wanted to say.
Thank you, Simone. Anyone would think it's by design. Any questions or perspectives to Simone? Looking forward to your involvement in that subcommittee. And then the audit committee of the 31st of May and the 13th of June. Julie?
Hi, Russell. I've given a verbal update last time regarding May, so I won't add anything other than to draw to attention the internal audit report. 9th of June was a meeting to actually approve all of the statutory reports, which went very successfully. So I'm not going to add anything to that.
Okay, great. Thank you. Any questions to Julie on the audit committee? Okay, and then the Foundation Group Strategy Committee report. Julie, what would you like to pull out, if anything?
Just to say that it shows the areas that we're going to be focused on in our strategy sessions in September, each of the trusts. We had the opportunity to have an update from Worcester, particularly around the international nurse recruitment. We've talked about that this afternoon. There was an excellent presentation around improvement and the introduction of Fab Friday at George Eliot Open to Change at Swift. And the report attaches the annual self-assessment of effectiveness.
Great. It's wonderful, I think, the work and quality improvement that Ali's been leading out of Wye Valley over the last couple of years. Any questions to Julie on the Foundation Group Committee report? Okay, so I think therefore we're on to any other business before questions from members of the public. Any other business from colleagues? Okay, we'll go then to questions from members of the public. Any questions from members of the public? David.
Thank you, Chair. They're not questions so much as a couple of statements on matters covered earlier in the agenda. I'd like to endorse what Glenn was saying about local supply of products as not necessarily the cheapest, but by far the best way of supplying products to the patients. And on the last point, if I may, Chair, I'd just like to say on behalf of your Patients Forum, Daljit, you have been an incredible director stroke chief nursing officer. We thank you for all you've done for the improvement of patient experience at the Trust. We will miss you, but we wish you lots of success in your new post, and we look forward to working with your successor. Thank you, Daljit.
Thank you, David. And Keith.
Thank you very much, Chair. Couple of things. Firstly, yeah, great we're doing research on what solar and things are going to go ahead. So there's never been a more important time to do that. One thing on the Ockenden report I noticed, question 5, was about maternity data. And I follow the NHS monthly maternity dashboard. And in December, January and February, the George Eliot Hospital data was missing. So when I looked at the number of births in Nuneaton and Bedworth, it said there was 20. Which I assume is actually the numbers that were born at the UHCW, and actually there was a hole where your data is. So it'd be useful to confirm that and get the missing data, because you print in your dashboard how many are born at the George Eliot, but that doesn't break it down like it goes through the system. And finally, can I just have confirmation on you've got 44 patients in the hospital with COVID, because that is something we should be pushing back to our society in Nuneaton and Bedworth to start to be more careful again, particularly around medical locations. Yeah, if you're going in the chemist or GP or the hospital, we really need to get in the wearing masks and things back again. And when you do need to meet someone, can you do it outside?
Yeah, no, point well made on that last point, Keith. And I know there's a lot of preparation work being done on the communication regarding public health and the COVID spike that's going on. Daljit, on that first point on, if you like, missing data, yes. Can you clarify, please?
Yes, I can do. Yes, you're right, Keith. We had some issues with an information team in submitting the data. That's now been resolved. So that information should be flowing through now. And it was largely due to some changes in staff, and it's quite complex. So we've been working with the central NHS team to try and get that corrected.
Great, thank you.
Can I just ask for a copy of that data, because on the public dashboard they do a monthly report, and if you don't submit on time, the public then can't see your data.
Okay.
What we'll do, Keith, is we'll pop it into the minutes so that everyone can see it, so that there's total transparency, but we'll make sure that happens. Okay, well, thank you for members of the public who have joined us. Can I just go back on something David said? Daljit, like I said at the start of the meeting, you'll be immensely missed. And I want the board to give Daljit a round of applause for phenomenal efforts, particularly over the last few years, leading the nursing team and being part of the whole executive board through an extremely challenging period. You'll be much missed, but you're much loved, and you're always welcome back here. Okay, so take care. Our next board is on the, just bear with me, the 6th of September. I look forward to seeing you there. For my board colleagues, we'll go into the confidential board at 25 to 4. Members of the public, I hope to see a number of you at the AGM at 4:30. See members of my board in 7 minutes. Bye-bye.